Thank you very much, Dr. Arif Said, for the kind introduction. And just a small announcement. Unfortunately, Dr. Babakar is unable to be with us today as it was planned in the schedule, and I'm giving this talk. And I would like also to welcome our virtual attendees. Now we have more than 2,000 people attending both lectures. So welcome. Okay, so I'll talk about a topic that I personally like, which is metabolic diseases causing seizures. So we'll give like a brief introduction, and then we'll talk a little about the approach. And then at the end, give some examples, because definitely we cannot cover everything, but just we'll give some examples of metabolic diseases that cause seizures, and many of them will be actually treatable conditions. So metabolic diseases, or we call them inborn errors of metabolism, are relatively uncommon cause of seizures in children. Still, we should consider them because many of these conditions can be treated. And if you treat the metabolic seizure, then you can control, if you treat the metabolic disease, then you can control seizures. And it's important to make the diagnosis early, because early diagnosis can prevent complications, or at least decrease complications. The list is very long. We have more than 200 metabolic conditions that are known to be associated with seizures. Sometimes seizures seizures are the main presenting part of the disease. Sometimes seizure is part of a complex neurological and metabolic manifestations. So when we introduce this term metabolic seizures, we mean like, okay, seizures caused by underlying inborn error of metabolism. So like a list of these conditions, of course, it's really long list. We have disorders of amino acid metabolism, disorders of energy like mitochondrial diseases, disorders of cofactors, really long list of conditions. But on the other side, I got like some treatable conditions, like for the classic example is phenylketonuria, urea cycle disorders, organic acidemias. These things can be treated, and if you treat them, then you control seizures. But how do metabolic diseases cause seizures? So we have different mechanisms. Like, for example, in urea cycle disorders, we have accumulation of ammonia, and ammonia is a toxic compound for the brain. So this can be a mechanism. In mitochondrial diseases, we have energy deficiency, and this can also lead to seizures. Many times we have cofactor deficiencies, and I'll give some examples. In neurotransmitter dysregulation, some conditions can cause that. And few conditions can even cause brain malformation, like Zellweger syndrome, as we will mention in some of the few slides. So now that after this brief introduction, we'll talk about like the approach. Now, we should consider metabolic diseases when we evaluate children with epilepsy. But in general, it's relatively uncommon to have seizure as the only presenting manifestation of a metabolic disease. So if you have only metabolic disease without anything, if you have only seizure without any other signs, then it is really unlikely to be metabolic diseases. Typically, we consider metabolic diseases when we have other things. And I tried to summarize, I'm sorry, I wanted to put them in one slide, because these are the things that we can, when to consider metabolic diseases. When we see a child with seizures, when to consider an underlying metabolic disease. If we have unexplained neonatal seizures, if we have early myoclonic epileptic encephalopathy with HIPS arrhythmia, if we have unexplained hypoxic ischemic encephalopathy, and we'll give like some examples of metabolic conditions that may mimic hypoxic ischemic encephalopathy. Refractory seizures deserve to be looked at. If we have seizures related to stress, fasting, or food intake, sometimes we have people with aversion to certain type of food, particularly proteins, like urea cycle conditions. Now, if we have other manifestations with seizures, like seizure plus developmental delay, or seizures with growth failure, or episodes of vomiting or lethargy, if parents are consanguineous, or if we have family history of seizures in the family, so definitely we need to think about inherited metabolic conditions. Again, if we do the exam and we find something suspicious like small head or large head, dysmorphic features, skin and hair manifestations, as we will talk in the few slides. And if you have seizures with metabolic derangement, seizure with hyperammonemia or metabolic acidosis or hypoglycemia, definitely in these situations, we need to seriously consider underlying metabolic disease causing epilepsy in these children. So how to find these points? Simply by history, examination, and basic workup. So in history, it's important to focus on development to see do we have developmental delay or not, to also get the information about the growth of the child, something unique about the diet of the child. If we have episodic features like recurrent vomiting or unexplained periods of lethargy. And of course, family history is very, very important. We'll ask about consanguinity. We'll ask about like a previous family history of similar cases with seizures or unexplained death. Now, in the exam, it says we have also, we need to look at certain things like head size, because as you see here, microcephaly can be associated with certain metabolic diseases. Macrocephaly can be associated with others. Dysmorphic features, coarse facial features. Definitely, we need to do a comprehensive eye exam because cherry red spots, for example, is associated with certain storage diseases. Lens dislocation can be seen in some metabolic conditions, mainly sulfite oxidase deficiency. Retinitis pigmentosa can be a feature for some conditions. Still have one more slide about this. Hepatosplenomegaly is something very important to look for. Skin and hair, dermatitis and hair changes, these can be associated with some cofactor and vitamin deficiencies. Stroke-like episodes, and the classic syndrome is MELAS, a mitochondrial disease that can be associated with stroke-like episodes. And of course, bone abnormalities. So we can get some clue from the history, some clues from the examination, and we need to do simple basic workup, because if we have hypoglycemia, for example, we need to consider metabolic conditions causing hypoglycemia, like fatty acid oxidation defects, or if we have metabolic acidosis or hyperammonemia or a persistent elevation of lactate, then all these are clues that can direct us in certain directions. But for lactate, it should be persistent, because like seizure by itself will cause elevation in lactate. Difficult sampling will cause elevation in lactate. So it should be like several samples to say this is like this lactate elevation is really significant. And sometimes we need to do second tier or even third tier of tests. Like if we want to investigate further, we have this suspicion of a metabolic disease, then the basic metabolic workup, what we call it like plasma amino acids, urine organic acids, and plasma acetylcarnitine profile can be done. Sometimes we need to take a CSF sample and do further testing like amino acids in CSF. And then if we have really strong suspicion about certain condition, then we can confirm that by either doing a genetic test or enzymatic test. Very good. Now for neuroimaging, yes, they can be used. Typically, they provide non-specific findings or normal in metabolic disease. We cannot use them to make a diagnosis. But we know like some metabolic conditions can be associated with certain neuroimaging abnormalities, like the classic example, like for Zellweger syndrome, for example, can be associated with gyral abnormalities. Corpus callosum agenesis can be associated with other metabolic diseases. And if we are doing the MRI, maybe it will be helpful to do MRS to look for lactate, for glycine, for creatine. These also can give us some clues about metabolic conditions. Okay, so this is the first part of the talk. Now let's talk about like some examples of, again, I just put few examples because we cannot cover much in this short time. Now, the first thing is to, if we have a child with metabolic disease and we are suspecting an inborn error of metabolism, is again, first is first. We need to review the history and examination and initial workup. Are we suspecting a specific condition? If yes, then we direct our workup to that specific condition. Like if we have sometimes we have like family history of a specific condition, then we can go directly and test for that condition. Now, the other important part to look at is metabolic derangements. Do we have hyperammonemia, hypoglycemia, acidosis, lactic acidemia? If we have any of these, then definitely we need to look at the conditions, the metabolic conditions that are associated with these metabolic derangements. Like, for example, if we have high ammonia, definitely we need to do workup for urea cycle disorders. Now, in certain situations when we have refractory seizures, particularly in neonates, we need to think about pyridoxine responsive seizures and pyridoxal phosphate responsive seizures. And these two conditions can be treated, and it's important to recognize them. This is why I will spend maybe 2 minutes talking about them, about pyridoxine dependent epilepsy, which is due to defect in an enzyme called antiquatin. Now, deficiency of this enzyme will result in accumulation of certain compounds, and these compounds will bind pyridoxal phosphate and cause deficiency of this essential cofactor. This cofactor is very important for neurotransmitters. This is why we have dysregulation of neurotransmitters and refractory seizures. And yeah, they present mainly with seizures plus other manifestations that can actually mimic hypoxic ischemic encephalopathy. And how to diagnose and treat at the same time. So we do this trial of pyridoxine IV with EEG monitoring, and it's like magic. When you give the IV medicine, seizure will stop, and even the EEG abnormalities will normalize within minutes. So this is really your cure, and you confirm your diagnosis. Of course, it's better to do, you need to do after that like biochemical assessments for urine and CSF to look for these compounds, and also we can confirm that genetically. And this is one of the conditions that can be treated with pyridoxine, which is like a vitamin or cofactor. Now, the other condition has similar clinical scenario, neonatal seizures, but typically these people do not respond to pyridoxine. They respond to pyridoxal phosphate, because the defect here in the enzyme that converts pyridoxine to pyridoxal phosphate, and pyridoxal phosphate is the active compound. So in this situation, we give pyridoxal phosphate. This is oral, and within hours, typically you have the response, and same thing, this condition is treated now with pyridoxal phosphate. Okay, now, if we need further, sometimes, of course, we need to do further evaluation. So if we suspect a metabolic condition, then actually taking a CSF sample is very important, because in CSF we can look at the amino acids, and the most important two amino acids to look at are serine and glycine, because these are associated with relatively, it's not really very uncommon, but these conditions, glycine encephalopathy and serine biosynthesis defects, are really, they cause like seizures are really main features in these conditions, and these will be diagnosed, will be suspected mainly by taking CSF amino acids. We should also take the folic acid and glucose. Now, if glucose is low, then this will be highly suggestive of a GLUT1 deficiency, which is deficiency in the transporter of a glucose to the brain. And in In this condition, we have, as I said, we have defect in the transporter that transports glucose to the brain. So we have low glucose in brain, and this will result in not only seizures, but of course delay, developmental delay, and the seizures typically worsen with fasting. The diagnosis is based on identifying low glucose in CSF and can be confirmed genetically. And again, this condition is we can do something about it. If we cannot use glucose, then brain can be forced to use the ketone bodies by ketogenic diet. So this is one of the examples where ketogenic diet can be very helpful. And the other one is folate. So if folate is low in CSF, then we should consider two conditions: methylene tetrahydrofolate reductase deficiency, the severe form, and cerebral folate deficiency. Now, for methylene tetrahydrofolate deficiency, we have defect in the enzyme that activates folate to the active form, and folate is important for many essentially processes, including like the methylation donor, and this will also involve in neurotransmitter synthesis. Now, seizures are an important feature of this condition, plus lethargy, feeding difficulties, severe developmental delay. We can diagnose these, suspect these conditions by finding low folate in CSF. So biochemical markers in the blood can be helpful. We can find like a low homocysteine, high homocysteine with low methionine, because this enzyme is involved also in conversion of homocysteine to methionine. And typically, these people can, will not say it's treatable condition, but betaine, which is methyl donor, can partially help these people. And the other condition is cerebral folate deficiency. In this condition, we have a problem with the transporter of folate to the brain. So folate cannot go to the brain, and of course, like seizures is one of seizures are one of the main features here, plus severe delay, movement disorder, ataxia, and we can find low folate in CSF, and the diagnosis can be confirmed molecularly by checking the sequencing of the gene. And again, this condition, if we start treatment early, you can make big difference in the course of the disease by using folinic acid, because folinic acid will go to the brain, but the methyl tetrahydrofolate will not. Very good. Then, like, these are like more of CSF tests. We can do many urine tests. The two important tests, one is for purine and pyrimidines in urine, because we have a big category of inborn errors of metabolism. We call them purine and disorders of purine and pyrimidine, disorders of purine and pyrimidine metabolism defects, and many of them present with seizures. And we have also, we can check guanidinoacetate, because creatine and guanidinoacetate, we have like few conditions due to defects in creatine metabolism defects. I will not talk much about this because we don't have much time, but I will move finally to important urine test, and relatively common in our region. When we have seizures and we need to do the workup, definitely we need to consider taking a urine sample for sulfocysteine, because this will be elevated in two important conditions, sulfite oxidase deficiency and molybdenum cofactor deficiency. Now, molybdenum is the cofactor for sulfite oxidase. So if you have deficiency in the cofactor or the enzyme itself, you have similar picture. We have accumulation of sulfite. Now we have the accumulation of the sulfites, which are toxic compounds causing not only seizures and delay and microcephaly, and this condition again can mimic hypoxic ischemic encephalopathy. It's a severe condition. both conditions are severe. Unfortunately, we don't really have treatment for these conditions except for one type. Next slide, I will say about it. But for diagnosis, yes, sulfocysteine, we used to do it in urine, but also you can do it in plasma. And you can confirm that by doing a genetic test for the sulfite oxidase gene or the genes responsible for synthesizing molybdenum cofactor. As I said, we don't have a treatment except one type of molybdenum cofactor deficiency, where we have a specific compound, cyclic pyrenopterin monophosphate. This is the precursor for molybdenum cofactor that we can use, but to have really good effect, it should be given early in the course of the disease. Other conditions are really, we don't have much we can't do much for, and they have really severe prognosis. So yeah, this is like summary of the condition, some conditions that can cause metabolic diseases and cause seizures, like metabolic disease causing seizures. Okay, so in conclusion, metabolic diseases are relatively uncommon causes for pediatric seizures. However, we should consider them when we evaluate children with seizures, because diagnosing them without delay can make, if you diagnose them early, you can start treatment early, and this can decrease or prevent complications. You can control seizures by treating the underlying cause. Oh, perfect. Thank you very much.